Hi, welcome to TCTAP. Today we're going to focus around complex PCI. Maybe I can ask the panel to introduce themselves. Maybe you can introduce yourself, please.
I'm Joo-Yong Hahn from Samsung Medical Center, Seoul, Korea.
Michael Lee from the United States.
Akiko Maehara from the Columbia University and the Cardiovascular Research Foundation.
I'm home in Severance Hospital.
So maybe we could start the discussion by discussing, what do you actually mean by complex PCI? Michael, maybe you can start off. How would you describe what complex PCI is?
As you mentioned, there's a very loose interpretation. What used to be considered complex PCI, like left main, as you see at this conference, it's basically a routine procedure.
Yes.
What I consider a complex procedure would be, let's say there's diffuse disease, calcium, bifurcation. But I think what really makes it more complex is that not only are you dealing with the angiographic issues, but you're also dealing with the patient, in particular the hemodynamics. And as we discussed, when somebody has an ejection fraction, let's say 30%, there are those who are well compensated, where those people with the blood pressure hovering around 90s, let's say if you do a right heart cath, their index is 1.8, their CPO is low. Those patients, I get concerned. So I think the best way to optimize these patients is volume optimize, diurese them, get that EDP less than 20, really make sure that they're not, and also when such patients are on the table, I usually have anesthesia as backup, just in case if they were to start going downhill, they're there to address their airways, whereas you could focus on the intervention itself.
I mean, we often talk about people that undertake complex PCIs, as a special breed of interventional cardiologists. I mean, Joo-Yong, maybe you can talk to us around, what do you think the skill set is that's required to undertake complex PCI?
I agree with Michael. So the whole risk profile is very important, but as an intervention cardiologist, I focus on the angiographic or procedural findings. For me, CTO and severe calcified lesions are most tough lesions, and we have to learn the basic skills, including low tabulator or anterior retrograde approaches. So that's the key factor for complex PCI.
Okay, I mean, how common is calcific disease in Korea? I mean, do you have it a lot in your cases?
Based on my personal
Yes,
experience,
yeah.
is that maybe it expected in around 20 or between 20 or 30 is that maybe the calcific region, and I think is that the complex PCI is it means that the more higher risk of poor outcome. Mm-hmm. So as you presented, why we need know about the complex lesion, identify the complex lesion characteristics, directly correlate with poor prognosis. What is the nature? But therefore, it is so individual. Is that the beginner, every case is complex, but the well-experienced and the CTO region is usually a complex PCI, but who have the 20 years of experience of the CTO and high volume is dependent. Yes. So, however, we need some communication for anyhow, this identity should be regarded as one of the complex. So therefore, we have some communication and consensus.
I mean, Akiko, we often think about calcific coronary disease as being complex, and in this meeting we've seen some really impressive calcific disease. And you gave a really great talk around calcified nodules. I mean, how common are calcified nodules, and do we know how they behave in PCI?
Okay, so by the way, starting with how much calcium in the United States, a lot. I think more than 30 for sure. Especially the Columbia, we have a referred hospital, and many of them was post-bypass cases. It's super calcified. So I would say at least like 40 more, we are looking for the very calcified region. Those are the baseline. And then out of those, calcified nodule prevalence is actually, if you look into the very, very severe calcium, defined, let's say, by IVAS OCT, more than 270 degrees of calcium, the prevalence of calcified node is already like 40%. But if you look into the calcium less than 180, it's almost none. So it's really correlate amount of the calcium and the presence of the calcified nodules. So overall, probably about 5 to 7%, that's the total population.
Yeah. And how do they behave, calcified nodules during PCI?
Yeah, so that's something unique because number one, we recently see the two different types of the calcified nodule. One is eruptive. It's like mostly at the time of the ACS. You see the rupture of the fibrous cap, and on the top, even that's calcium, there is some thrombus or fibrin. That's typically, but not always, easy to redistribute, and then we see that relatively okay expansion. But the other one is, I would call this healed calcified nodule, is already cap on the top, and looks like the chunk of the like calcium stone on the top of the plaque. So if that is not eruptive, they are behave. It's no change, no deform. So when you open those artery, you just stretching the non-calcified nodule side and then pushing one side. Then if you do much, you make the perforation in the non-calcium side. So that's the behavior looks like.
Yeah. Michael, I mean, we in the United States and in the UK and Europe, we have IVL. I mean, do we need any other tools apart from IVL in managing calcified lesions?
90% of the time, I think you could get away with IVL.
Okay.
There are those times where it's just unable to cross. So there are some maneuvers you can do. You could pre-dilate. There's a technique of kind of using a submarine approach where you inflate a low diameter balloon, you deflate and you push forward the guideline or a guide cap or guidezilla. But still, there are times where you just cannot cross. And one of my concerns is that this day and age where the fellows are just trained in IVL, they don't know how to do rotablator. They don't know how to use orbital atherectomy. My analogy would be the following. You know, we were in the era where we had ciphers.
Yes.
And remember, there were trucks. And we had to push, yes. Right? Now the stents are much more slick. They're deliverable. So now people just think, once we get it there, the game is over. We just inflate the stent and we're done. So I think there's always going to be a need for atherectomy. And I've had times where IVL just had not appropriately or adequately plaque modified, and you have to go back. But you should be able to be very facile with both techniques.
I mean, Joo-Yong, in South Korea, I understand that you don't have IVL, you don't have orbital atherectomies. I mean, what's your approach in managing these heavily calcified lesions when you don't have so much?
If a balloon is uncrossable or not fully dilated, we have to use rotablator. But okay. In many cases, the adequate expansion is not easy to obtain with only rotablator. In the case, the imaging is very essential, and NC balloon is helpful. But in special cases, we have to rely on the super high pressure balloon.
I mean, do you have much experience with these super high pressure balloons? I mean, when in this talk I was seeing and my heart was jumping out of my chest.
Actually, I don't have experience in the supra high pressure balloon. It is not commonly available still, and I'd like to emphasize what is that the reality is identification calcific nodule. Usually, we do the common practice, but the scenario of the PCI is some different for the usual case. What is that? And then realize that, okay, give me some imaging, and do imaging, and then realize, oh, this is a real complex, and the really worst one. So therefore, when we expect that this kind of lesion, first identify with the imaging and easily catch up. What is the risk? Yeah. And then select what is the best option for the adequate treatment. I think that is the most important.
Yeah. I think I totally agree. The reason was we developed one bunch of the different calcium score because the purpose is really we to have the good prediction and better choice of the which device, right? So we develop, and then we use mostly IVAS at the Columbia, and then what's happening is actually we downgrade the calcium modification than before. So we are picking up the very important case, rota first, and then afterwards, rota trypsi, we do the IVL on top. Those things we do a lot for the very specific cases. But if the calcium is very short, even circumferential, we know that can be fractured, even the non-compliant balloon. Go ahead, the balloon, just do it. And then it's very predictable. So I think knowing more and more what's happening inside, that's really help us. And then, for example, angiographically, you see the big calcium, but sometimes calcium is everything is deep. And then actually nothing effect of the center expansion. So that's, I totally agree.
Yeah, I mean, it's interesting that you say that, because often, you sort of do a case, you see what looks like really bad calcification, you say to the people in the cath lab, okay, let's get the rotablation set ready. You do the imaging, you think, actually, I don't need any of this.
Or medial calcification, right? Then obviously it's a need for any atherectomy, although there's some evidence that perhaps IVL might be effective in the medial calcification.
I mean, one of the things I was going to talk about is particularly challenges in the US. We were talking before the interview around, clearly patients that we're undertaking PCI on are becoming more and more complex. But against that, in many healthcare systems, we have a lot of low volume operators that may be doing 10, 20 PCIs a year. I mean, how do you think a healthcare system should sort of manage that situation?
I think there's two potential scenarios. Number one, let's say you have an operator in the middle of nowhere and they're not skilled with atherectomy. And so they just may want to just go ahead and just blast it with a non-compliant balloon. I'd rather them have IVL, where anybody could use a balloon. So at least you're doing some degree of plaque modification. At the same time, on the opposite spectrum, if you know you're not dealing with these patients too often, just go ahead and call Columbia. Go ahead and call, Severance, et cetera, where you know that they're going to get best optimal outcomes because they're used to dealing with these patients. And if the patient were to decompensate, they have the backup to deal with these patients, whether it be ECMO or advanced therapies, et cetera.
I mean, we've seen, it's always good fun in these meetings to see CTO cases. I mean, I guess maybe for the South Korean members of the interview panel, how common is CTO in South Korea?
In PCI cases, I think 10 or 15% comprise CTO cases.
Actually, usually in our lab, annually to the 1,500 annually. Among them, I think it's the 200 annually CTO, and we intentionally focus in the CTO cases some specific expert. We have the 8 interventionists in our lab, but this case is a CTO, have a CTO and just the non-CTO lesion. We fix it in the non-CTO, and the CTO is the transferred some special expert, and intentionally increase his experience and more, because as I said, 200 of it is divided by 8.
Yes.
So what is the annual number of cases is the improvement. What is our goal is translate in the patient outcome overall, patient who visit our institute. So there is our strategy.
What are the skills that are required of a CTO operator?
Such kind of the strategy was determined 10 years ago.
Yes.
And before the 10 years ago, I'm not a CTO guy. The skill is maybe is a moderate, and the selection of it, improvement is the 1 or 3, within 1 or 3 years, that technically very, very rapidly increased, because he only focused in the CTO.
So Michael, I've seen some of your live cases. You're a complex PCI guy. I mean, there's still a lot of debate about whether we should be actually doing CTO cases. I mean, where do you come in on that?
Well, Asan presented data at the ACC which showed no real benefit.
Yes.
But I think if you carefully select your patients, I think, for example, LAD, they're not a surgical candidate. They have some degree of viability. They failed medical therapy. And also the degree of ischemic burden. I think, 10% would probably be a good cutoff. So there are multiple factors involved. But as a whole, and I think as Dr. Hong mentioned, in the United States, because we do much more CABG, whereas in Asia, it's just more of a cultural issue. So I think they are used to treating these patients who would otherwise want at least an attempt at a CTO compared to, let's say, open heart surgery.
Okay. I mean, in terms of, in these meetings, we often talk around, all the great complex PCI that we can do, but very little is spoken about, risk factor control, particularly lipid management. I mean, in South Korea, who manages that? Is it you as the cardiologist? Is it the general practitioners? How much of these newer therapies like PCSK9 inhibitors, some of the other things that have been coming through, have entered into South Korea?
So in Korea, most patients see the interventional cardiologist who underwent PCI, and especially the 1 year or 2 year after the index PCI. We do use maximum intensity statin, ezetimibe, and in some cases PCSK9 inhibitor, but the reimbursement of PCSK9 inhibitor is quite strict. But if the medical insurance cover PCSK9 inhibitor, I do use the PCSK9 inhibitor.
Okay. Maybe the last question for each of you, but keep it brief, is if there's one piece of advice you can give to the complex PCI operator, what would it be? Maybe I could start with you.
That's a very good question. But as Professor Hong mentioned, it is important to know my level of skill or techniques. So if I were a beginner, I have to learn from seniors. Sometimes they can procedure together, and inexperienced operators most benefit from the imaging devices. So I personally use the intravascular imaging devices mainly for complex lesions, but as you mentioned, the term of complex is very difficult to define. So for young interventionists, I recommend to use intravascular imaging.
Okay. So again, keeping it brief, what's your one piece of advice, Michael?
Imaging, never underestimate the amount of calcium, and optimize the patient if they have some degree of LV function, optimize their volume status.
Okay. Akiko?
Use image.
What's your final word? What's your advice?
It depends on the situation. What I mean is a complex lesion is a real situation. Therefore, it depends on what is the most simple, shortest way to fix it. That is all. And the second one is look at your patient, not the angiogram. What I mean is only angiogram. What is the patient age? Middle 90, and try to fix everything. What are you doing? So it depends on the situation.
So I guess my final piece of advice is always think about risk and calculate risk. As cardiologists, we're not very good at assessing risk, and so use validated risk scores, and as you say, think about the whole patient rather than the angiogram in front of you. So with that, I'd like to thank you all for joining us at TCTAP, and congratulations to all the faculty, because I think it's been a really great meeting. Thank you.
Thank you.
Thank you.